thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled, Why is Palliative Care Still Misunderstood in 2025? Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by communities so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area, all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce our today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter your questions into the chat function found at the bottom of the Zoom window at any time. Without further ado, I'd like to introduce our workshop speaker. Glen Komatsu, MD, serves as Chief Medical Officer for Providence Hospice Los Angeles and Regional Palliative Care Southern California, Medical Director for Providence Kids Care Pediatric Hospice, Director of the Edmond R. and Virginia G. Doak Center for Palliative Care at Providence Little Company of Mary Medical Center Torrance, Co-Chair of Bioethics at Providence Little Company of Mary Medical Center South Bay, and Senior Advisor for Strategy and Education to Providence Institute for Human Caring. Thank you so much, Dr. Komatsu, for being here with us today.
Thanks, Rebecca. That was way too long, but okay. So thank you all for joining today. It is my custom to start all my sessions and meetings with a moment to arrive, just taking a moment to settle and separate from the busyness of the morning and to bring yourselves to be fully present right here, right now. So I invite you to put your feet on the ground, to sit up straight with your shoulders relaxed. And I invite you to close your eyes or gently lower your gaze and just take a few deep breaths. Breathing in to your nose and out to your mouth. Breathing in and breathing out. I'd also like to take this opportunity to acknowledge and have a moment of silence for Judith Opdahl, the longtime executive director of this organization. And she is one of the main reasons why I continue to support and be involved with the cancer support community. So she recently passed away end of last year. So let's just take a few moments of silence in her honor. Thank you. Today's topic is, why do people still not know what palliative care is? Or even if you've heard about it, you can't quite explain it. And really, I've been trying to explain palliative care for the past 20 years. 20 years was when I started my work in this field after doing fellowship in Boston. And, you know, it's not an easy field to explain. You know, it's not like cardiology, obviously, everything to do with the heart, like pediatrics, everything to do with children, or even oncology, everything to do with cancer. So palliative care is not that simple. So it's really our fault in the field that you still don't quite get this. And so we have done some work on this in the field, like how can we explain this in a way that the public would understand it and not be too frightened. So I'm going to explain sort of palliative care, hospice, advanced care planning, and whole person care today in simpler terms, complete with a story about each one. And then we'll have time. I'll pause for questions after each section, because I want to make sure that, this is as clear as it can be for all of you in the audience. Next slide. So these are the topics I'm going to cover today. And I really want this to be a conversation and a dialogue. It's really kind of boring for me if I'm talking the whole time. The other thing I'll say as a disclaimer is please excuse my hoarse voice. I had my own cancer experience about 15 years ago, and as a result, I have some residual radiation damage to my tongue and my throat, which makes my voice sound the way it does. So if you don't understand me, just ask me to repeat, and I will do so. Next slide. So this is a definition of palliative care that was researched by a major body in palliative care called the Center for Advancement of Palliative Care, based out of Mount Sinai in New York. And this is a definition I've used in the past. It's very complete, but still not, people still don't quite understand what palliative care, even seeing this definition. But I'm going to start with this because I think it's a good touchstone. It is a specialized medical care, is a specialty of medicine that was just recognized in 2006 for people living with a serious illness. So notice it does not say terminal illness, it says serious illness. And we focus on providing relief from symptoms, of course, but also the stress of that illness. And our goal is to help the patient and family have a better quality of life. Next slide. Palliative care is a team sport. So there are nurses, social workers, chaplains, alongside physicians who work with your other doctors to provide an extra layer of support. So we don't replace anybody. So I'm going to use cancer-based examples today for obvious reasons. We don't replace your oncologist. Your oncologist is still primarily responsible for cancer treatment. But sometimes they don't have the time or the experience to address your pain, your nausea, your insomnia, your depression, your anxiety. So we provide palliative care based on your needs, not your prognosis. So we treat patients that will be cured of their cancer. So not just patients that are terminal or incurable. So therefore, we can give palliative care at any age, at any stage of a serious illness, and can be provided alongside curative treatment. So we have a whole program for children in palliative care. And, those children are still getting aggressive treatment. Next slide. So I want to just offer a few slides that highlight, the big points for you that you would most likely care about. And that is, the first one is this concept of an extra layer of support. Oncologists have hard jobs, right? They have a lot to keep track of. They're always keeping track of the latest research, latest treatments, and helping you present that to you. So they do help with pain and nausea to a certain level. They have their usual sort of meds that they use for pain and for nausea, for instance, especially related to chemotherapy. But if you have more than the average amount of pain or nausea, then a lot of times they don't have sort of more choices or more answers. So that is what palliative care can do. Also, in palliative care, we really emphasize your quality of life. Like, what's important to you? What do you need to do to live your life while you're getting cancer treatment? So again, that's not the focus of oncologists. They're focused on your cancer, as they should be. But we can help you with things like, what's going to help me get back to work? What's going to help me, get back to school? I really want to go hiking again. I want to go on vacations with my family. How can I do those things while balancing my cancer treatment? Next slide. So our feeling is you can live well while living with cancer. And for most people, that means being able to spend more time at home with their friends and family, and at the same time, get the best medical care for their cancer. Next slide. One thing that is a problem in our current healthcare system is that there are a lot of specialists involved with people's care, and we don't communicate with each other. So I'm sure many of you have had experience of that, even if you don't have cancer. So we can help you with that in palliative care. We can interpret what your other doctors have said. If you have doctors that tend to use a lot of medical jargon and medical terminology that you're too polite to ask them, what are you talking about? I didn't understand anything you said. Most people are embarrassed to ask the doctors when they don't understand what the doctor is saying. So we can help with that. We can also call doctors like your oncologist and say, your patient still is not understanding kind of what the plan is. The other thing that's very common is that the different specialists are saying things slightly differently, and that gets confusing. One of the issues with subspecialists is they really know a lot about their organ, their part of the body, but they don't always sort of tell you the context. Like your cancer, for instance, could be staying the same or getting worse, but the nephrologist, the kidney doctor comes and says, "Oh, your kidneys are doing great." And so that's good that your kidneys are doing great, but you're still worried about your cancer. So it's like those kind of different messages can be confusing for patients. So we can help interpret kind of what all the different doctors are saying and help you put things in some context. Next slide. So having cancer is hard. There's a lot of stuff going on, not just with your treatment, but with everybody in your family is affected by your cancer diagnosis. So we will help you with all of your concerns. So for instance, you're worried about your daughter or your son who may be still in college, and they are thinking, oh, we need to drop out of college and come back home and take care of mom. And how do you manage that? Who's talking to your son or daughter? Another thing is we talk to grandkids, for instance. So you're very close to your grandkids. They don't understand what's going on, and people are afraid to talk to them, or they don't know how to talk to them. And we can help you with that because children are part of most families, not every family, but most families. And so I have a strong bias that kids need to be included in these conversations to the level that they want to be. So some kids want to be very involved, some kids do not. But you have to know how to help them be involved and be able to talk to them in a developmentally appropriate way. So you cannot talk to a 3-year-old the same way you talk to an 8-year-old, or the same way you talk to a 12-year-old or a young adult. So I'm biased, obviously, because I am a pediatrician by background. So I always want kids to be included. Another concern that people have are spiritual concerns and spiritual pain. So like, why did God allow me to have cancer? Am I being punished? What I've been faithful my whole life. I go to church regularly. I believe in God. Why did God let me have cancer? So it's not like we have all the answers, but we can help you talk about that because it's very different for each person and each person's faith. So we have chaplains as a part of our palliative care programs for the most part. And, any of us really can talk about it, but they have particular expertise in specific religious traditions. The other thing is that many people don't go to church these days. They don't identify themselves as religious, but they still identify themselves as spiritual. So spirituality in the largest sense means, what are the things that give your life meaning? Is it family? Is it nature? Is whatever it is it playing the piano? we can help you have a space to talk about the things that are important to you. So, next slide. So, palliative care can be offered at any stage of a serious illness, as I said before, but sometimes you have to ask for palliative care. So in oncology, palliative care is not top of mind for them. Your cancer is top of mind, as it should be. So it doesn't hurt to say, do you think palliative care would be helpful? Can I get a referral to palliative care? And so depending on where you're going for your oncology treatment, all the major cancer centers have palliative care services. We at Providence are one of the few places that have an outpatient palliative care service. So you just need to ask, and start with your oncologist or primary care physician and see what they say. All right, next slide. So let me tell you a story about palliative care, and then we'll pause for questions. So I had a patient who was a longtime employee of the hospital at where I worked at Little Company, and she was diagnosed with breast cancer, and unfortunately, the breast cancer spread to her bones. Many of you know that breast cancer really has been transformed into a chronic disease by oncologists and the advances in breast cancer treatment. And she wanted to keep working. She needed the insurance, but because it had spread to her bones, she was in a lot of pain. So one of the things I helped her with in palliative care was her pain management. And I prescribed doses of morphine, both long-acting and short-acting, that really allowed her to have a good quality of life, and it allowed her to continue working, which she loved to do. So she was my patient for probably 5 years. And so all that time, we would meet every other month, every third month, and I would ask her about her pain. Her pain did increase over time, but we just kept up with it, and we kept adjusting the dose, and she did really well. And she was able to continue working. She was able to keep traveling with her husband and enjoy life. So unfortunately, after 5 years, her cancer progressed and she was not able to work and went on to hospice. But this is an example of palliative care being very helpful when people are sick, but not close to the end.
Thank you. We have a question, Dr. Komatsu.
Yes.
What happens when family members disagree with the patient when the oncologist wants further treatment? Family agrees, but the patient prefers a palliative care course.
Yeah, that is always a problem. When doctors disagree, it's a problem. When patients and families disagree, it's a problem. So, and again, we don't have a magic wand to make this kind of conflict go away. But one thing we do is we sit down, we invite the patient and family to sit down together and have a family meeting. And what we do in palliative care is we moderate or mediate that meeting. And we give all sides a chance to speak and talk about their wishes and what's important. And we give the patient a chance to talk and explain why they feel the way they do. And then we give the family a chance to talk about why the way they feel, the way they feel. And what we try to point out is sort of the fact that patients have a right to decide what happens to their body. Because after all, it's their life, their dignity that's at stake. But we try to sort of mediate some middle ground where maybe there can be some compromise on both sides. Sometimes some families can reach that middle ground, some families cannot. Some families, there's been a lot of dysfunction for many years, and we can't fix that, right? But we can help both sides feel heard and listened to. And a lot of times that's what families have a hard time with. Families are good at talking, but they're not good at listening. So we really make the time and space where we encourage each side to both talk and listen. Listening is key. I had to become a better listener to do this work, quite honestly. Some of you have probably heard me say this before, but I had to go to Harvard to learn how to listen. I was an okay listener before I went to my fellowship, but I got much better after I came back. And it's something I'm still working on, as my wife will tell you. All right. Thank you for that question. Really great question.
Yes, we have another question.
Go ahead.
Can palliative care be used after breast reconstruction surgery when family is not very helpful or supportive? Do they help with transportation for follow-up visits?
Yeah, so palliative care is a medical specialty. So, a lot of what people need are in the social determinants of health. They need proper food, they need transportation, and we can help guide patients, but we cannot provide it. Like we can recommend transportation services in your community that you can access, but we cannot provide the transportation ourselves. We can give you resources.
There was a follow-up question to this question. Can they send a nurse?
So it depends on the program. Some programs are strictly clinic-based, so you have to go into the clinic to an appointment to see all the staff. We have a community-based program in Providence where we can send staff out to the home, nurses and physicians or nurse practitioners. But most of the follow-up is done by phone, and we cannot provide those services on an emergency basis, like in the middle of the night, weekends, or holidays. And that's a big difference between palliative care and hospice.
Thank you, Dr. Komatsu. If there are any other questions, feel free to put into the chat and we can share the next pausing point.
Well,
Thank you.
there is another question. It would only be needed for a week following surgery. So that kind of service is more in the realm of home health. So home health is set up to provide short-term services for a specific problem, like post-op care after surgery, wound care, IV antibiotics at home for several weeks following a hospitalization, physical therapy after hip replacement, things like that. So there's very, very specific criteria for home health services that is different than palliative care. Palliative care is services that are offered in the context of an ongoing serious illness.
Thank you. I think that is it for questions for now.
All right, we can always come back to palliative care. All right, now I want to talk about hospice. So rather than give you a whole slide about, or slides on what the Medicare hospice service provides, I'm just going to give you a sort of a bigger picture context that hospice is really palliative care, but in the last chapter of your life. So Medicare says we have to say you have 6 months or less to live. But in fact, we doctors are very poor, not very good at predicting how long people live. But that's what Medicare guidelines sort of state that we have to do. So it's the same kind of care, but it's in the last chapter of people's lives. But it is a more complete set of services in the fact that we can provide equipment, medications, all the staff come to wherever the patient lives, whether it's home, skilled nursing facility, assisted living, or boarding care. So hospice also provides 24/7 availability, and we can send out nurses in the middle of the night, weekends, and holidays. So it's a more complete set of services, but the type of care is the same as in palliative care. We do the same type of pain management, nausea management, all the symptom management piece is the same. So most people think about, next slide, most people think about hospice as, giving up hope, giving up, like people are gonna abandon them. And that's nothing could be further from the truth. So this is a robust set of services to really help you and be there when you need help. So whenever, wherever, however you need us, we're there to support you. Next slide. We will meet you where you are. So every person is different. We don't treat every person with pancreatic cancer the same. Some people want more pain meds and they're okay with being a little sleepier. Some people want less pain meds because spending more time awake is their priority. Some people don't want any pain meds because, they just don't like the way pain meds make them feel. So we don't make anybody do anything they don't want. So we spend time getting to know you, understanding your philosophy of life, your values, what's important to you. And we'll help you, get to where you need to be. We'll help you with the things that are important to you. not the things that are important to us. Next slide. We want you to feel not so alone. When you're done with cancer treatment, you don't have all those doctors and nurses and appointments that kind of become your community, right? When you're in the middle of treatment and you get to know them, you chat with them, they become part of your family. So once you leave or finish cancer treatment, you can go back to the oncologist if you want, even if you're on hospice. You can go back and have consultations, but hospice is for people that are finished with aggressive cancer treatment. If you're still on cancer treatment, you would not be on hospice. So we're here to help you focus on what's most important, to help you, really capture those precious moments, that grandchild's graduation, the grandchild's wedding, your son's, new job or new home. Whatever is precious to you, it's gonna be precious to us in terms of, helping you get there. Next slide. So that really is the focus of hospice. So let me tell you a hospice story. One of the things that we see is that patients sometimes really have a hard time giving up treatment, and they feel like they're letting the oncologist down, they're letting their families down, and they need to keep going. And the oncologist refers the patient to hospice. And so we have a conversation with them before we even admit them. And we tell them, you didn't fail anybody. You didn't fail your oncologist. You didn't fail your family. You did the best you could. One of the things that really I try to fight against is the military metaphors that are associated with cancer. Like, if I never see an obituary that says they lost their valiant battle with cancer, it's like, it's not a war. Wars indicate winners and losers, and there's no winners or losers in cancer. You didn't lose because your cancer advanced and kept growing. I don't like the whole fighting metaphor, because if the cancer is growing, then the implication of that metaphor is you did not fight hard enough. That's not the case. That's almost never the case. You did the best you could. The oncologists did the best they could. Your families are doing the best they can. But cancer is a really hard disease. And we haven't cured cancer yet. I mean, we've cured some kinds of cancer. I'm a living testament to that. But I had a very early stage, and fortunate to have a type of cancer that was curable. But there are many cancers that are not curable, and also cancers that are curable in one person, but not curable in the next. And so a lot of cancer treatment and a lot about cancer, we just don't understand. And so, I mean, I don't think cancer will be cured in my lifetime. I think that's still an aspirational goal, but my personal opinion is that it will never be cured because we're living so long. And so the mutations in our bodies, the little mistakes inside the cells, the genetic mistakes, have more of a chance to express themselves, and then they turn into cancer. When the average lifespan in this country was 45 years, people did not die of cancer very often. Now that it's in the late 70s, cancer is much more prevalent. All right, I'll pause there and take any questions about hospice.
Yes. Well, some of them are about palliative care.
Oh, okay, we can
yeah.
go back to that.
Yeah. What other serious illnesses other than cancer qualify for palliative care?
Great question. I was going to use some other examples, but because this is the cancer support community, I kind of restricted it to cancer, but Alzheimer's is a big one. But you have to be at an advanced stage of Alzheimer's. And by advanced stage, usually what we see for Alzheimer's patients that qualify for hospice are they're bedbound, no longer walking, having difficulty eating, swallowing, very poor appetite, losing weight, and unable to speak more than a word or two, or sometimes not able to speak at all. Those are the advanced stages of Alzheimer's and when hospice is appropriate. Because as most of you know, you can live with Alzheimer's for a number of years, 5 to 10 years. So it's really at the advanced stages that hospice is appropriate. Other common diseases we see in adult hospice is advanced Parkinson's disease, people that have suffered large strokes and are partially paralyzed. They may or may not have a feeding tube. Heart failure, advanced heart disease that, the patients are having more and more trouble breathing. Same with lung disease, like COPD or emphysema, pulmonary fibrosis. People are in oxygen continuously and really having a hard time eating, having a hard time maintaining weight, hard time doing any of the activities of daily living.
Dr. Watts, so I want to clarify that this is for palliative care or hospice that you just shared.
So you can always start on palliative care, but this was more, the advanced stages are more for hospice. The early stages of any of those diseases
Okay.
could qualify for palliative care.
Okay. So this is just in case you don't cover later. So will insurance cover palliative care? And if you talk about it later, we can talk about it then.
Yeah, no, that is another really good question. Medicare currently does not recognize palliative care as a benefit. So it's really hard to start a palliative care program. So especially a palliative care clinic. So hospice is 100% covered by Medicare and most insurances, but palliative care is not. So that's why palliative care services are much more spotty and depends on the institution you're working with, where you get your health care.
Thank you. And just kind of follow up about, serious illnesses and palliative care. So
Yep.
for Alzheimer's and palliative care, can it be used for someone with early onset?
If the patient is struggling, like having pain, having hallucinations, agitation that is not well controlled, then they would qualify for palliative care. If the patient is forgetful, um, pleasantly confused, I'll say, then there's not much that, palliative care has to offer in terms of treatment or medication. So it depends if there's a problem with the patient.
Thank you. This is just more of a comment. Thank you. I don't like to see those words warrior, battle, or fight, etc. either. This is a comment. Thank you.
Yeah,
I think that's it for questions for now.
great. All right, let's move on to advanced planning.
Oh, sorry, Dr. Komatsu, we have one more question.
Yeah,
About palliative care. Can you
yeah,
be on palliative care while receiving chemotherapy?
absolutely. So remember my slide, it says you can have palliative care while receiving curative treatment, whether it's radiation, chemotherapy, blood transfusions, any of that. All right. So I just want to say a word about advanced care planning. Um, every hospital asks you this question. Do you have an advanced directive when you get admitted to the hospital? We have to do that by law. And so advanced care planning has been sort of conflated with these documents. And so I kind of want to kind of talk about it in a little bit more nuanced way because the documents are very triggering and really people think, oh, this is a code switch for pulling the plug. And they just want me to say, okay, to pulling the plug. And that is not what we're talking about at all. So advanced care planning is about having a say in your care. It's about you deciding what care and treatment you want. We in medicine kind of assume that every patient we see wants everything done, when in fact, that is not the case because people have different values and they have different philosophies of life, right? So if you want to have a say in your care, you need to think about advanced care planning. You do not have to have treatments if you don't want them. And the treatments are only going to work if they work for you. Next slide. So you don't ever have to fill out any of those pieces of paper, like a living will, an advance directive, a POLST form, which is physician's orders for life-sustaining treatment. The main thing is to have the conversation with the people who matter to you and who you want to speak for you and with you about your care and treatment. So it's not about the piece of paper. It's about having the conversation. The more you speak up, the better the health care that you receive will be lined up with your values and your philosophy. So it's helpful to have the documents in writing because, we are kind of a more legalistic society, and some doctors are really focused on that. But for me, it's the conversations that are most important by far. If you fill out the documents, but you never talk to anybody, and you don't tell the person, oh, by the way, you're my surrogate decision maker, it's like, that is not ideal. Because then they'll be thrust into that role without any kind of preparation, without any conversation from you. Next slide. So not only do you talk to the people that matter to you, which I'm not assuming is your family, it could be your best friend, could be your niece or nephew, your sister or brother, could be anybody that you pick that will follow your wishes. You also need to tell your doctors what matters most to you, so the doctors know, that what your wishes are. Because if they know, if your family knows, your loved ones, your friends, whoever you pick as your surrogate, you have a much greater chance of getting the health care that you want and need. But we need to do this together. It can't be one person writing out things out on a piece of paper and then assuming that everything will fall into place and they will get their wishes followed. I wish I could say that if you had the discussion, you fill out all the paperwork, you're guaranteed to have your wishes followed. And unfortunately, because of our sort of broken healthcare system and all the sort of the silos that comprise healthcare, like if you get an emergency room doctor that doesn't take the time to read your documents, doesn't take time to talk to your family, that doctor is going to kind of do what they think is best. So there's no guarantees, unfortunately, but the chances are much, much better of getting your wishes followed if you engage in advanced care planning, which means both having the conversation and filling out the paperwork. Next slide. So let me tell you a story about my friend, my patient, Tim. And Tim's wife was a palliative care patient when I was working in the hospital, and I took care of her. She unfortunately died in the hospital. But after that experience, he was adamant. He said, I do not want my life prolonged, and if there's no hope of recovery. And he goes, he told me his wishes, he told his family, he told his, he actually eventually remarried. He told his new wife, this is what I want. He told everybody, all of us. And he told us, he reminded us kind of when we saw him. And so when Tim suffered a series of strokes at the end of his life and was in and out of consciousness, some days he was lucid, Some days he was very confused. Everybody was very clear. His daughter, his wife, I was very clear. And so we transitioned him to hospice because we knew his wishes and we kept him comfortable on hospice in his home. And he died a month later. So, but he was very insistent and persistent in telling all of us his wishes. And that was really helpful in taking care of him and helpful in taking care of him in the way that he wanted to be taken care of. All right, I'll pause for questions about advanced directives.
Thank you, Dr. Komatsu. If there are any questions, feel free to put them into the chat. I think we might be okay then, or maybe you can address them after the next section.
Sure.
Thank you.
All right. We're almost done here. So what do I mean by whole person care? This term is used by a lot of health systems these days, and most people assume, all right, it means we're going to take care of a person, body, mind, and spirit, right? The whole person. But I want to present a different definition of whole person care that I learned from colleagues at McGill University in Montreal, where not only did they written extensively about this and written books about whole person care, but they actually teach whole person care in their medical school. It's the only medical school in Canada and the United States that I'm aware of that has a specific curriculum devoted to this concept of whole person care. And so there's a couple of key concepts that I want to help familiarize yourself with. So the broad definition is that we will do everything we can to fix what can be fixed. But another big part of this is a relationship, a caring relationship with people and their families, and treating them as unique individuals. So, and think about our relationship with them as a journey, not where we are the providers giving them treatments and they just go home and do it, but really a journey of accompaniment where we walk together side by side as they learn how to live with their illness. So, and it's a journey that's directed towards healing if possible. So, what do I mean by healing versus curing? Next slide. So we kind of use those terms interchangeably, but I would submit that they're very different. So curing is what we always want, and curing is the primary goal of medicine, as it should be, that we're going to, make the disease that you have go away, or we're going to fix an injury, and the goal is living, is survival, and we want our life to go back to normal. So if you have a pneumonia, we're going to give you the right treatment for it. You're going to be cured of the pneumonia and go back to live your life. So if you have a broken leg, we're going to do surgery, fix that leg so you can get back to walking and back to working or living your life, right? So everybody understands what curing is. Healing, on the other hand, next slide, is different because there are so many things in medicine that we cannot cure. Even common things like diabetes, like asthma, like high blood pressure, like we can treat those things, but we can't cure them. So what do I mean then by healing? Healing is a different process, which the person or the patient has to do the work, the hard work of coming to terms with this illness, chronic, serious, or terminal illness. And they have to redefine themselves that now I'm not the person I was before. I'm now a person with asthma, or I'm a person with high blood pressure. And what does that mean? Or I'm a person with cancer. And the person in the healing process is able to recognize that, life is still worth living, that there are still possibilities for joy, meaning, and gratitude, even though they have an illness that cannot be cured. Do you see how that's different? So, next slide. So, an example of healing would be we have patients on hospice that are dying. They know they're dying, and they are sad about that, but they don't dwell on it. They say things like, I've lived a good life. I've lived a long life. I'm very proud of my family. I'm grateful for my family. I'm grateful for having lived such a long and fulfilling life. That's what healing looks like. And we didn't tell them to think that. We in Palliative Care or Hospice, people came to that conclusion. They come to that conclusion on their own. I try to help them think about it. The glass is half full versus always half empty. Some people can get there and some people cannot. Some people are not going to go gently into this good night, like Robert Frost talks about in his poem. They're going to go kicking and screaming. They want to be in the ICU, intubated on machines, being coded till the last minute. And if that's what they want, then we're going to help them with that too. But healing is not that. And so what we try to do in palliative care and hospice is create the conditions where healing is possible, where the psychosocial pain is addressed, the worries about their children, grandchildren, partner, their well-being, the spiritual pain is addressed, like can they come to terms and make peace with God about their cancer or whatever their disease is. And, the conditions then for healing are there. Can we relieve their physical pain so they can think about getting to healing? We can create the conditions for healing, but we cannot make healing happen. I cannot make healing happen in my patients. Not within my power. That was really helpful for me to learn that as a physician, especially as a palliative care and hospice physician, because I thought people that died very hard deaths were my fault. And it's not my fault. I never had the power to begin with. So last slide. So this is my favorite, my auxiliary quote, which I try to keep in mind. I've learned that people will forget what you said, people will forget what you did, but people will not forget how you made them feel. And I've seen that over and over again. All right. Thank you so much for your attention. We have time for more questions.
Wonderful. Thank you so much, Dr. Komatsu, for sharing all this information. Okay, so first one is thank you for doing what you do. And then thank you for the information today. It was very appreciated. Next, the question is, what if you aren't sure? What if you're hospitalized and don't know or don't understand your prognosis?
Yeah.
What should you do?
We doctors do not like to have that conversation. I'm just being honest. Oncologists don't like to have that conversation in general. And again, I'm not speaking for all oncologists. I'm just saying, when people ask, doctors say things like, I don't have a crystal ball. Nobody knows. But, we actually do have an idea. I'll just give you an insider's sort of insight. We actually do know because we've seen patients like you before, but we still don't like to say because a lot of doctors feel that giving you a prognosis will take away your hope. And I think that is true sometimes. But when patients ask me directly, Doc, how long do I have? And I said, I always sort of double check and say, do you want my honest opinion? And if they say yes, I give them my honest opinion. And I don't give them a number. I say, I think you have years to live. I think you have months to live. I think you have weeks to live. I think you have hours to live. So I give those kinds of time frames. I think patients deserve to know if they want to know, but not all my colleagues agree with me.
Thank you for your honesty. Yes, there's next question. I have a advance directive prepared, but don't know how quite to file it with the hospital.
Yeah.
How is this done? Most of my treatment is through Providence, but should it be filed with Torrance Memorial in case that's where I end up through ambulance?
Yeah, that's a really good question. It should be filed wherever you have a medical chart. As you can drop it off or send it to the Health Information Department at Providence, You can bring it with you if you're having surgery or if you're going to the ER. It should be scanned and, now with electronic records, we can scan your advance directive into your electronic record. Absolutely. You should carry it with you at all times, at least not the whole thing, but the part that says who speaks for you and what the summary of your wishes. That's usually 1 or 2 pages.
Thank you, Dr. Komatsu. And just to let everyone know, we do have a workshop coming up in April that is doing a deeper dive into the advance directive and the post form. So that is on Friday, April 25th at 1, and it'll be hybrid. So if you're interested in doing a deeper dive of workshop just focused on this, please feel free to go to our website to register. There's many, many thank yous. Oh, okay. So
Yeah, that's great, Rebecca. That makes me feel less guilty about not covering that in detail.
we can't have you covering everything. We appreciate all that you've covered. Absolutely. It is teamwork here. If there are any other questions, we do have some extra time. Feel free to put them into the chat. If you would like to ask it verbally, feel free to unmute, and then that'll let me know that you have a question that you want to ask. But I'm just going to give it a minute just in case people are typing. Thank you again, Dr. Komatsu. You're right. I think it's still a confusing topic and it's hard to navigate. So it's nice to have someone just explain it so that when we do talk to our providers, we're better informed.
Yeah, I will be surprised if you ask me for the same topic next year.
Yeah. Well, we always have new participants coming in. Yes,
Yeah,
great presentation. Yes, I agree. All
great.
right. If there are no other questions, I just want to thank Dr. Komatsu again for your time and your expertise and your just continued support. We just really appreciate it.
Yeah. No, thank you all for joining, taking time out of your busy days to for this presentation. And thanks, Rebecca, for making it really easy for me to do.